Okay, I'm going to give an example case and the treatment plan for that case. So the patient comes in for a perceptual speech evaluation following a history of cleft palate. Their speech characteristics include mid-dorsum palatal stop substitutions for k, g, t, and d at all levels of speech production, so word, phrase, sentence, and conversation. Their resonance is characterized by mild hypernasality and frequent audible air nasal emission on most pressure consonants except for k and g. Mere fog testing confirmed nasal air emission during production of p, b, t, and d, but not k or g. Oral examination revealed a 3 mm oral nasal fistula near the incisive foramen. And these findings suggest both obligatory errors and compensatory articulation errors. So for their diagnosis, we diagnosed them with velopharyngeal dysfunction due to the fistula near the incisive foramen, compensatory articulation errors, which are those mid-dorsum palatal stop substitutions, and mild hypernasality. The justification for that is that the nasal air emission is on interior oral pressure sounds in absence of emission on k or g, which indicates that the airflow is escaping through the fistula and not through the velopharyngeal port. The mid-dorsum palatal stop substitutions are learned compensatory articulations that are developed to avoid air loss through the fistula. And since the hypernasality is mild and velopharyngeal closure appears adequate for k and g, the primary structural concern is the fistula rather than velopharyngeal insufficiency. For our goals, for long-term, our goal is that the patient will produce accurate oral pressure consonants at the sentence and conversational level with minimal cues, and that the patient will maintain oral airflow without nasal emission during connected speech, given surgical correction or prosthetic management of the fistula as indicated. For our short-term goals, we have that the patient will produce correct lingual, alveolar, and velar placements in isolation and single words with moderate verbal and visual cues, and that the patient will reduce use of mid-dorsum palatal substitutions by establishing correct placement using visual and tactile feedback like a mirror, straw, those sorts of things. Our evidence for treatment plans, ASHA emphasizes that therapy for cleft-related speech should target compensatory errors rather than obligatory errors caused by structure. So the compensatory errors, the mid-dorsum palatal stops, can be eliminated with direct articulation therapy, focusing on correct placement, airflow direction, and auditory feedback. However, obligatory errors, such as those caused by nasal air emission from the fistula, cannot be corrected by speech therapy, and they will require surgical repair for complete resolution. Techniques supported by evidence for this could include auditory feedback tools, minimal pairs and placement contrast, and biofeedback approaches. Our next steps would be to refer to a cleft palate team and surgeon to evaluate need for fistula repair or prosthetic obturation given persistent nasal air emission through the anterior opening. We want to initiate articulation therapy targeting elimination of compensatory errors, which are those mid-dorsum palatal stops. We want to provide parent and home education on correct placement cues and feedback tools. We want to reevaluate resonance and nasal emission post-repair to determine if hypernasality or emission persists, and we want to continue collaborating with the cleft team for ongoing surgical, dental, and speech management.